Hi.
Welcome back. It's been fun to see you in the discussions over the last day. It's nice that now we're going to get to hear you speak and tell us your story. So I'm going to start out by introducing Kat Glore. So Catherine Glore is learning to live well with persistent neuropathic pain. At her first diagnosis of chronic progressive pain disorder, she learned to meditate and somewhat navigate the healthcare system. After receiving her second, she began discovering pain science and is finding strength in mostly gentle movement. She has a special interest in the ways that we communicate about pain, but claims no expertise beyond her lived experience. She received a diagnosis of trigeminal neuralgia in 2015 and of CRPS in 2019. In her current role, she generates numbers for a pain scale that has no meaning to her and spends countless hours speaking to insurance adjusters. She has login credentials for 6 unique patient portals.
Those are Make that 7 now.
Oh gosh, 7. I'll tell you what, I had a panic attack trying to log into one of my 2 patient portals because the passwords and the logins, and so well done. I think you're smarter than I am. Also, sorry, that's what you have to use your brain space on. So I'm very excited to hear your story and what you have to teach us. But first of all, we have some show and tell, I believe.
We do, and I brought this. And you're wondering, why in the world does Kat have a clothespin in her hand? Well, about a year and a half ago, when a cast first came off of my arm and my fingers weren't working, one of the first exercises that I was doing in physical therapy was using pins. It felt, I'll be honest, kind of pointless at the beginning. I didn't really see how I would need to develop the skill of moving marbles from one tray to another in my personal life. But then coronavirus hit, and there were no masks to be found. And so my wife and I began sewing, or actually she began sewing, and I began pressing and clipping masks. By my count, there were about 16 clips each time that we did one. And see, I actually have the skills now. And each of those multiplied by about 1,000 masks that we made, I learned that there are indeed practical applications to some of the therapeutic exercises that I've done in the clinic.
Well, that is a relief, and it's really awesome to actually, thank you for making all of those masks. That's a lot of hard work and really good use of your therapeutic skills. Okay, well, I think that we are ready to get started. We have about 2 minutes. If there's anything else you'd like to share with the audience before we get you rolling.
No, first, that I just want to reflect on the past 2 days and how incredible it has been, as someone who is primarily a patient in this space, to have access to the wisdom and the knowledge that's been shared from all of the presenters here. And you'll hear this a bit in my presentation, but one of the tricky things, I think, coming into the space for someone like me is that we don't have the same vocabulary. We don't understand in the same way. We certainly have a deep level of understanding, but aren't necessarily using the same language. And over the past 2 days, I've certainly been really active on Twitter, attempting to share some of the things that I've been learning, not just with clinicians who follow me, but with the other individuals who are living with persistent pain. And I would really like to give a shout out to San Diego Pain Summit for including the patient voice in all of this, because it really does make a difference.
Absolutely. That was so beautifully said. And I think it's a great reminder for every clinician or practitioner who ever watches this. This is why we're here, is to help people. It's not about us. It's about the people we're trying to help. And maybe we should use words more often, even in our interactions at conferences, that are more understandable and inclusive, perhaps, to keep the patients involved and get their feedback and involvement more often. Okay, I will stop talking, and then I will let Rajam hit play on your presentation, and we'll see you back here at the end.
Hi there, I'm Kat. I use she, her pronouns, and I live in the foothills of Appalachia, traditionally home to the Adena culture and the Ohio Hopewell tradition, later home to the Shawnee people. Today, it's the poorest county of Ohio, full of tiny little towns that have been decimated by the overdose epidemic. I'm not a clinician or a scientist. I haven't written any papers. I don't have fancy degrees. What I do have, quite simply, is pain. High-impact neuropathic pain. I'm here today as a patient, although, quite honestly, I'm not even sure I'm a successful patient, at least when it comes to pain. I'm right in the messy middle, in the thick of things right now, trying to understand it all. And you're just watching me figure it out in real time. In a way, you're helping me figure it all out. Pain, of course, is something that we all experience. And when someone asks me to tell them my pain story, I'm never quite sure where to start, never certain how to package my personhood into one neat little anecdote. But I guess we have to start somewhere. So let's start with a fracture. I fell. 2 words, subject, verb, the simplest of sentences. 2 little words that led to a complex pain situation. Literally, in this case, complex regional pain syndrome, CRPS, formerly RSD, regional sympathetic dystrophy. 2 new acronyms I learned on this journey I'm about to share with you. And while this is a story about pain, this is also a story about language, about meaning, and about how the ways in which we see and understand the world shape how we exist within it. I mean, you and I may use the same acronyms, share the same words to discuss what I'm experiencing, but I don't think we always mean the same thing. And I do think that could harm both of us. So here's one version of my story. Patient is a 40-something-year-old female, history of migraine, trigeminal neuralgia, and related anxiety. On initial exam, presented as alert and oriented times whatever, sat comfortably in examination room, answered questions appropriately, rated pain at a 7 out of 10. Radiographs showed displaced olecranon fracture, referred for surgery. Open reduction, internal fixation, ORIF, another new acronym for me, with a tricep repair for good measure. 2 weeks after that, the left upper extremity, LUE, was cast. Patient reported stinging in the hand, but appeared neurovascularly intact. Patient tolerated casting well, reported pain of 3 out of 10 with medication. 10 days after that, patient was presented for an unexpected appointment, having increased pain and being concerned about an infection. Upon removal of cast, wound was clean and dry with mild ecchymosis. Fiberglass cast reapplied. 3 weeks later, patient presented to the ER with nausea, increased pain and swelling. Laboratory findings and X-ray of the LUE were unremarkable. Later that week, cast removed. Patient reported burning pain in the hand. X-ray showed healing olecranon fracture. Elbow hinge brace, referral to physical therapy. Therapist noted patient is highly motivated but has impairments in pain, strength, range of motion, flexibility, all of which affect the patient's ability to reach, stress, bathe, sleep, carry. Initial quick dash functional measure limitation, 96%. And while therapy progressed, recovery was slow. Patient continued to note burning pain in the hand, now traveling up the forearm. Therapist noted abnormal pigmentation of hand/forearm, reticular-looking rash. EMG noted partial axonal injury, referred to pain management for likely CRPS. Examination of LUE revealed darkening and discoloration of the left hand and forearm. Skin was cold to touch. Edema on the dorsal hand and in the fingers. Skin of the LUE was smooth and non-elastic. Evidence of significant joint stiffness, dystrophic changes in the nails and hair of the left hand. Evidence of allodynia on the dorsal aspect of the left hand, significant restriction of range of motion. Diagnosis of CRPS confirmed by independent medical examiner. Again, and again, and again, and again. Stellate ganglion blocks. Continued physical therapy, including graded motor imagery, desensitization exercises. Over the course of a year, range of motion, function improved, constant pain still reported at between 4 to 8 out of 10. Having failed multiple treatments and declined a spinal cord stimulator, patient has been referred to another new practice pending insurer approval. That's the story told on my chart, a biomedical journey of an arm that if we're focused on pain, largely features failure and dead ends. That's the story every new provider reads, but is that enough to understand the patient? I mean, how can you possibly understand with so little information? How can you possibly understand me, my motivations and goals, complicated things like pain, if you don't understand my experience? So here's another version of that story, one using my words. I was at an important work meeting when I fell, embarrassingly, in front of colleagues and a lobby full of strangers. Flat on my back, hitting my head and my elbow first, apparently. I waved off help initially, but finally I decided to go to an urgent care, who sent me to another urgent care, who took x-rays, confirmed the fracture, gave me what it turns out was a child-sized sling, and told me to follow up closer to home, which I did. Surgery went well, although I was surprised at how much I hurt afterwards. I'd been living with trigeminal neuralgia for about 5 years at that point, and I identified as someone with a pretty high pain tolerance, but this was rough. I was in a splint for about a week after surgery, which then transitioned to a shiny purple cast. Setting it, I was told to bend it as far as I could without pain, but that didn't make sense because there was pain at any angle. But I started to flex, and as soon as I winced, I was stopped, and we set the arm at about 30 degrees. I went home, and over the following days and weeks, the pain continued to just get worse. It was transitioning more to a burning in my hand and what felt like liquid dripping down my forearm. I was concerned, so I called my doctor. The shiny purple cast came off. The clinician verified that that sensation was all in my head, and a new purple cast went on, this time a little less shiny because, quite frankly, I have learned my lesson regarding casts and glitter. But still, things just didn't feel right. I was in so much pain, and yet I'd spent my entire life seeing happy kids running around playgrounds waving casts just like mine. Why was I so weak? What was going on? I had already had my cast removed at one point, only to discover that nothing was wrong, so I didn't bother reaching back out. And when I was asked to give a pain score, I was charting a 6 or a 7. Providers ask for that number all of the time, but they've never asked what it means to me. When I was first introduced to the 10-point visual analog scale, I was told that a 10 was the worst pain imaginable. And I've got a pretty good imagination, so I've never logged a 10. What I would call a 9 had only happened once in my life at that point, and I ended up in the emergency room. At an 8, it becomes difficult to breathe. Did my 6s and 7s mean the same thing to the person I was giving the score to? I never even thought to qualify, and to be honest, as a woman with a history of anxiety and a pain complaint, I didn't expect to be taken seriously anyway. Casts weren't supposed to hurt. I downplayed the pain. And quite honestly, after a while, those numbers make less and less sense anyway, at least when it comes to persistent pain. I wish I'd been given 2 scales, maybe one for the strength of the sensation, the biomedical, and one for how it was affecting me, the psychosocial. Those numbers don't always match, and looking at it in that way might help me recognize the many things that affect that pain experience. But anyway, there came a day when it was all just too much. My hand was red and shiny, swollen, and hot. I still had weird sensations traveling up and down my arm. I couldn't control my heart rate. I came close to passing out every time I stood up. And when I consulted Dr. Google, I read that this was potentially an emergency. So I called my doctor, was sent to the ER, only to discover once again that there was nothing wrong. I was given something for pain, and after my blood pressure was again under control, was sent home to wait for the cast removal at the end of the week. I was pretty sure they just thought I was a drug seeker, but I was happy to go home. And by the time the cast finally came off, I didn't think I could bear another hour with it on. It hurt so much. It was such a relief to get it off, to finally envision getting use of my arm again, to be able to shower, dress myself in normal clothes, do my hair, to drive to work instead of trying to work from home with awful satellite internet. But the limb that came out of that cast wasn't ready to do any of those things. I could barely touch my thumb and index finger together. The elbow and wrist hardly moved. The skin was so sensitive that even air movement hurt. As the swelling increased and then went down, increased and then went down, my skin started to molt. The burning in my arm was starting to feel like my face, which up until that point was the worst thing that had ever happened to me. And that was terrifying. But now the cast was off, and I believed that everything would get better quickly. I was in an adjustable brace, and ortho had said I should be able to increase my range of motion by about 10 degrees a week. I learned how to change the settings, confident in hitting my goals, because I am someone who hits my goals, and I happily trotted off to PT. And the clinic is a happy place for me. I'm comfortable in a clinical setting. I worked in a hospital as a teen and throughout college as I was considering a potential career in healthcare. And while that wasn't my path, I do have several family members who are healthcare providers, and I believed wholeheartedly in the power of science and medicine to fix something as simple as a broken bone. I came in with a certain level of trust that not everyone enjoys, and I really do believe that that made a difference. Because even with that trust, everything was still so painful. This burning, bone-crushing sensation in my hand was now starting to travel up my forearm. And, this newly exposed skin felt perpetually raw, like sandpaper being scraped against a sunburn. But I already asked for help twice, when I thought my incision was leaking, when I ended up in the ER. And each time I learned that there was no reason for my pain, that nothing was, quote unquote, wrong. I learned that I was weak. What I didn't learn was that my pain was out of proportion. I learned that my reaction was. But so we started rehabbing the arm. On my first visit to physical therapy, I remember explaining that more than anything, I needed to put my hair in a ponytail. It was how I managed the trigeminal neuralgia. I couldn't have hair touching my face. I couldn't use a blow dryer, and I'm not quite ready to shave my head. So the only way I knew how to get through my day was with a ponytail. I just spent a couple months begging people to braid my hair for me, and I just wanted to be independent again. But when I reviewed the clinical notes afterwards, I saw goals written, but they weren't mine. A targeted acceptable pain level that we never discussed. Flexion of 100 degrees. The next visit, I again mentioned my ponytail, this time asking what degree of flexion I'd need in order to do that. And I was given a number far beyond my charted goal. I thought that meant I'd never get there. The message I got was that I'd never be able to tame my hair again. I'd never be able to manage my face again. A focus on my hair might seem vain from the outside, but I'd lost my primary tool for managing my pain. I lost control. What probably seemed to the clinician like just checking the appropriate boxes, envisioning the appropriate amount of progress we could make in the sessions allotted, it devastated me without him even knowing. And at that point, we believed we were just treating an injury, rehabbing a broken arm, so perhaps a full psychosocially informed intake wasn't necessary. Still, I would have loved to have been asked what my goals were, or even just ask questions that helped me recognize them. You'll actually find an excellent list of proposed in-depth questions from this 2016 paper, Listening is Therapy. And I would like to reiterate that, yes, it is. Patient interviewing from a pain science perspective. And I do recommend exploring the paper. But I didn't need the perfect initial intake exam to keep going back. I believed it would work. And so I was in clinic 2 or 3 times a week, doing everything asked of me. And yet the progress was so slow that it felt like there wasn't any at all. The lock on that brace wasn't moving, and I felt like a failure. The exercises, even just simple flexion stretches they were excruciating, but I did them. There were tears, both in the clinic and at home, but I kept going. I also kept Googling, trying to figure out what a normal recovery was supposed to look like. And it didn't look like mine. My arm didn't work, and it hurt so much. Like I said previously, I don't expect my pain to be believed. In fact, coming into this, I'd already experienced a clinical encounter where I was explicitly told there was nothing wrong with me when I was searching for a second opinion with a TN diagnosis. And on top of that explicit invalidation, there were countless implicit suggestions from my family, from others in my life, that I'd been exaggerating the pain in my face and now my arm. That stuff sticks with you, and And the self-doubt can be paralyzing. I was coming into the clinic twice a week, trying to get my fingers to touch, painfully stretching my joints, and just feeling weaker and weaker instead of stronger and stronger. And that was until the PTA, who actually pushed me harder than the DPT overseeing my care at that point, suggested that I might want to follow up with my doctor. And I felt validated for the first time. Recognition that this wasn't normal and wasn't all in my head. Later, I saw she'd been charting objective signs for a while without mentioning anything to me about the unusual presentation. And I'm actually really grateful for the documentation. I went back to ortho and received a diagnosis, CRPS. It had been mentioned previously, but the first time I heard that acronym, it was followed by, but you don't have the skin changes we'd expect. And I didn't at that exam, but if the clinician had instead asked if I'd seen any color change, et cetera, instead of just telling me what she didn't see, I did have information I could have shared. No matter though, because by now things were getting pretty obvious. As she now confirmed the diagnosis, I remember her giving this sad little shake of her head and telling me that it's very hard to treat and beyond their scope of practice, that I should get a referral and a pamphlet on the way out. She was trying to set reasonable expectations for what came next, but what I heard was essentially, you're on your own, especially since I somehow missed the pamphlet on the way out. But hey, who needs patient handouts when you've got the internet, even slow satellite internet? I did what everyone does, and I went home and I Googled, which is how I found out that now for the second time in my life, I was diagnosed with something nicknamed the suicide disease. Talk about nasibic language, but chronic, progressive, potentially, poorly understood, and painful. So painful. And I already knew pain. The shocks I'd been getting to my face had turned my world upside down several years before, but I developed some coping skills, a meditation practice, and the anticonvulsant and antispasmodic I was on helped keep me functional. What I wanted, what I value more than anything is information, knowledge. So I started reading everything I could get my hands on indiscriminately. And information seemed to fall into one of two categories, either scientific papers that were a tough slog to understand, assuming I could even get beyond the paywall, or patient spaces that seemed dominated by doom and gloom, horrific limb photos as people in pain were trying to share their misery. I felt scared. I felt abandoned. The pain was continuing to get worse, and I was getting increasingly despondent, I guess. I shared my diagnosis with my sister, who happens to be an OT and just happened to have done some continuing ed earlier that week that included GMI, graded motor imagery, another new acronym. She suggested that I look into it, and I did. I learned. Again, two little words, subject, verb, yet another life-changing sentence. Because when I took to Google to search for GMI instead of symptoms or a diagnosis, I discovered so much more. GMI led me to NOI Group, the Neuro-Orthopedic Institute in Australia, and the work of Lorimer Moseley and David Butler. Suddenly, instead of sifting through photos of bloated, discolored limbs, I was reading stories of hope. Instead of sifting through PubMed with a dictionary, I was learning basic pain neuroscience using stories and language that I spoke. I was beginning to understand. For the very first time, I realized that hurt doesn't necessarily equal harm. And I cannot overstate the importance of that understanding. But also, if only understanding that concept were enough, and if only it could be gifted, dropped magically from the scientist or provider's brain directly, immediately into mine. But my life is so much bigger, so much more complicated than that simple concept. And yes, I was starting to get a better understanding of pain, but knowing the difference between nociception and perception isn't enough to make it go away, to counteract the entire pain experience. It was really a sad day when I realized I couldn't learn my way out of pain, that you couldn't pain-splain me into wellness. And as this was happening, as I was learning more about CRPS and pain, I was also seeking treatment within a pretty complicated healthcare system. one that I don't believe puts the patient first. I mean, in theory, my diagnosis came fairly easily. It took just a few months between the onset of symptoms and the first time a clinician said the words. I was showing pretty much every objective clinical sign on the Budapest criteria. It made sense. And when I was sent to another physician, this time a physiatrist specializing in pain management, the diagnosis was confirmed, in theory, because that wasn't enough to trigger treatment. My access to healthcare, at least in this case, is overseen by a managed care organization, and without them accepting the diagnosis, there was nothing more that I could do. I mean, I was learning more about CRPS, reading that my best chance at a better prognosis was early and aggressive treatment, and yet, to my mind anyway, not getting any at all. It was Schrodinger's diagnosis, simultaneously confirmed and denied, depending on who was looking at it, or at least looking at my medical records, since clinical encounters were pretty much few and far between. And even though the physicians who had seen me all agreed, even a couple of clinicians that I just saw socially outside of a clinical context remarked on the obvious appearance of the arm, but with the system denying anything was wrong, I was trapped in self-doubt. I mean, maybe it really was all in my head. Maybe it was something else, but how was I supposed to figure out what it was, find a way out without medical experts guiding me, treating me? I felt so all alone. I was learning that best practices with something like this are to establish a multidisciplinary team, and yet I felt like I had no one. My primary care provider has no experience with the condition and said that she wasn't able to help. She was giving me accurate information about her experience and scope, but what I heard again is that I was on my own. My, quote, physician of record with the injury is an orthopedic surgeon, a DO with a great reputation, fantastic communication and clinical skills, but he was clear that this was beyond his scope of practice. My neurologist couldn't help as this injury was being treated through a separate insurance, and even though the meds he prescribes are likely helping the pain in my arm as well, he's not authorized to treat the arm and wouldn't be reimbursed for his services even if this was something he was willing to take on. Anything that pain management was recommending, a topical analgesic, nerve blocks, were being denied. I was struggling to work, struggling just to get through the day, and I didn't see any way out. It kept getting worse. I felt trapped, terrified, abandoned. I felt pain and little else. I was pain and little else. I found myself looking up a suicide prevention hotline. I read stories of people who had also been in this really dark place. And while I never called, never quite got that close, from where I'm sitting, there can be a certain amount of comfort found in acknowledging that if all else fails, there is a way to stop pain. But when your entire world becomes pain, it's hard to see anything else. And while I never admitted just how dark things had gotten to a healthcare provider, to anyone actually until this very moment, I did express frustration about the perceived lack of care, about all of the dead ends. And the next physician I was allowed to see was an independent medical examiner. Not for treatment, but to test for truth. And just a note here, within my insurance system, it's not the IASP Budapest criteria that's used, but the AMA Guides to Impairment to diagnose CRPS. And this guideline states that in order to confirm the diagnosis, I had to be showing 8 of 11 objective clinical signs concurrently during the exam. And as 2 of those were imaging studies that I hadn't had, I didn't really expect to have the diagnosis confirmed. In a way, I still didn't really trust that I had it without it, but I still went for my exam with a glimmer of hope it would lead to treatment of some kind. And that was the first of many mandated exams. I've still had more appointments with IMEs than an actual treating physician, have had my moral integrity examined much more often than my body. And to be honest, those physicians have all started to blend together. There's the one that examined every inch of my arm closely, his nose just centimeters from my skin. The one whose daughter's getting married. The one who came at me with a reflex hammer before I stopped him. even though I was afraid it would mean a black mark on my record, a potential excuse for discharge, denying care. There's the one who refused to answer any questions, even general inquiries related to inflammation, instead telling me that your own doctor needs to tell you these things. I didn't bother trying to explain that I don't have my own doctor for this. And then there's the one who took over 20 minutes with me, a luxuriously long encounter, validated my experience, told me how rare this was, but still gave me hope, saying it was probably too early to give up, that things could get better. Honestly, that's probably what I needed most in my clinical encounters. Not necessarily a specific medical intervention, but hope. Belief that things could get better. Someone who listened in a way that made me feel understood. When I felt like control had just been wrestled away from me, what I needed more than anything was help recognizing and realizing my own self-efficacy. But before I could find hope, I first needed validation, proof it's not all in my head. I'm incredibly lucky in a way that CRPS is a pain syndrome that can be seen. And even so, I felt like I spent months in limbo before the diagnosis was officially confirmed. And why is that important? It's when something has a name, it becomes real. It exists. And often there's a history and a solution, a community with the same label that I can learn from. So after my third official diagnosis, finally came an approved treatment, stellate ganglion blocks. And the first one was amazing. Awkward and uncomfortable, lying on an operating table as a group of gowned people jabbed things into my neck. As I sat up from the procedure, I broke into tears, but they were tears of happiness, of relief, because as I sat up, my arm felt, it felt like an arm. Not only was the pain nearly gone, but I hadn't realized really until that moment just how disconnected I'd felt from the limb. Even if you don't call it pain, I have constant feedback, constant abnormal sensations, burning, buzzing, squeezing, crushing, coming from that arm. And after the procedure, it got quiet, nearly normal for a few days. 2 weeks later, I had my second stellate ganglion block. During the procedure this time, I heard the surgeon mention that whatever magic potion they were injecting seemed to be headed more toward my face than down the arm. And it was certainly more uncomfortable than the first one, even though I knew what to expect this time. But as this one concluded, I did feel a reduction in pain in the arm, and of course, in addition to a lot of flushing in my face, but this one wasn't as magical as the first. And this time I had some serious discomfort in my neck, a burning at the injection site, a tightness, the occasional electric jolts that increased until it started feeling a lot just like the arm that was dangling down below it. What had felt like a possible solution turned into new weird pain. The risk-reward ratio changed, and not knowing whether additional blocks may be more like the first or potentially just lead to a spread of this wonky new nerve condition I had, I decided not to continue with them. I was afraid to ask for painkillers and just proving I was a drug seeker, and I wasn't willing to consider a spinal cord stimulator, no matter how often they pushed. So that was the end of the road for that particular pain management practice. And as a rural patient with limited access and a particularly difficult insurance, it would have been easy to slip back into that deep, dark hole. But I didn't. And here's why. My constant throughout all of this was physical therapy. I couldn't find a CRPS specialist, could seldom even access those who were approved to treat me by the system, but I was still in the clinic about twice a week. And once the CRPS diagnosis was confirmed, I was seeing the same physio each time. And with all of these frustrations and changes and fear, there was one constant and one place where I felt believed most of the time. And I felt seen and heard, not always understood. I at least believed that there was someone who cared. I knew that for those 2 hours a week, I would feel less alone. And that's not to say that my experience was perfect. I don't believe that any of us has ever experienced perfect care where all of our needs were met, all of our questions answered, but it was enough to keep me going. Even as my knowledge and understanding of CRPS, maybe even of pain, surpassed that of my young clinician, we had established trust, and that therapeutic alliance was my lifeline. As I was researching, slogging through papers, increasing my vocabulary, I had someone I could talk to and ask questions of. I mean, sure, the exercises were important, but I wasn't there for the pulleys or the paraffin. What kept me coming was the human connection. In fact, if you look at the clinical notes from an early session, what's written is IASTM and what to me looked like a flattened magic wand rubbed up and down my arm, you'd see it noted that I said it felt good. The clinician probably thought I meant it relieved the pain, and I guess it did in a way, but it wasn't the sensation that was reduced. What felt good about that passive manual therapy, a very small part of my overall treatment, I would like to add, but what felt good was the care that I perceived in the touch. Here was another human being who recognized my pain and was actively doing something they thought would help. And what enabled me to move through the pain, to actually get on that arm bike week after week, even as it flared not only my hand and arm, but my face, was having someone there to bear witness, to hold space, to just be with me through the struggle. And especially when exploring new and weird modalities like mirror therapy, that trust is so essential. And so I leaned in hard. Physical therapy was where I felt my best, even though ironically, it's also where I felt a lot of pain. And so in between sessions, I was doing my exercises and learning more about the theories behind my treatment. I've always been more brain than body, so, I needed that understanding to push through. I kept digging through online resources. I spent a lot of time on the PT subreddit while still combing through everything I could find from Noi Group. I discovered Body and Mind and learned that there were all sorts of really smart scientists studying this thing I was living with. Not just TN, not just CRPS, but pain in general. And they were having conversations with each other, asking really interesting questions, and I was able to observe, even from here. The more I learned, the more I felt like I regained control over my experience. And honestly, I think that's where the true healing began. Online, on social media. It was in community and in finding, or at least ascribing, meaning to the whole thing. When I couldn't get access, couldn't find resources locally, I looked online. I did a self-management workshop with a pain toolkit based in the UK and a series of Zoom sessions with another British pain coach. I had conversations with physios from around the world, and as I was being invited into these online interactions, my vocabulary increased. In addition to all these new acronyms, CRPS, LUE, there were words like allodynia, hyperalgesia, catastrophization, neuroplasticity. As I was better able to name and describe my experience, I was better able to understand it. In naming things, I was reducing fear. And social media can be an incredibly powerful tool in sharing information, but clinicians and pain patients pretty much exist in separate bubbles. We use different language. What that means is that even if you're sharing excellent advice, incredible evidence-based resources, someone like me may still find roadblocks to access unless we're willing and able to code switch, to enter your space and learn your language. I wonder sometimes how much my understanding, my functional progress has been dependent upon my training as a translator. Simply increasing my vocabulary. In naming things, I take back control. Which was incredibly important, especially as the CRPS spread. I know there's some controversy over the concept of spreading CRPS. The simple diagnosis itself can be controversial. One of the first papers I read was this one, where Giovanni Alaskan wrote, "There are only few diseases that have such a controversial history as the complex regional pain syndrome. Even its denomination underwent several changes to emphasize the prevalent pathogenic beliefs developed through the history of medicine." But by now, I was starting to learn to trust myself with my new vocabulary, believe that I knew my body better than any clinician, no matter what a managed care organization might believe. So when my right foot started showing symptoms after a simple toe stub, about 9 months after the initial injury, I was more readily able to accept my body's reaction. 5 months after that, another minor trauma, this time just the simple act of using an aerosol can, spread to more pain and paresthesia in the right hand and arm. Neither of these have been accepted by my insurer, by the way, which means no treatment has been authorized for the foot and the right arm. It's frustrating. I have one insurer, one set of providers who treat the neuropathic pain in my face, another insurer, another set of providers who, in theory, given enough appeals and paperwork, treat the neuropathic pain in my arm. No one's been assigned my right arm, my right foot, and even though healthcare economics require me to divvy up my body into acceptable chunks to remember the login credentials for, I think, now 6 separate patient portals, I'm not a collection of body parts and diagnostic codes. I'm one unique human, having my unique pain experience. I'm not a left olecranon fracture. I'm the human who chooses a purple cast filled with glitter. So when I come into your clinic and I say I'm in pain, it's not just the physical sensation that's causing hurt. It's everything that surrounds that. It's the change in my relationships, the need to redefine who I am and what I'm capable of. The burning sucks, but not as much as an inhumane system that treats me or my pain as a number, a malingerer, or an anonymous source of debit or credit. I really don't like the warrior framework that we often see from people living with persistent pain or chronic illness. And while I believe that acceptance is much more crucial than fighting pain, the truth is I've had to learn to fight against a system that, hopefully unintentionally is creating more harm than good with regards to persistent pain. And I've made progress. After nearly 18 months now, my range of motion is approaching quote unquote normal. Perhaps not thanks to our healthcare system, but in spite of it. I put this ponytail in myself, even if I did have to flip myself upside down to do it. Today, my baseline pain is more of a 4 than an 8. It hasn't gone away, but better self-management skills mean that I can still mostly live the life that I want. Because I have the education, the privilege, the curiosity to seek answers and support outside of that system. And that's not to say I haven't experienced some excellent clinical encounters. While I've been discharged from his practice now, my physio was with me throughout most of this time. It may have been the internet that first taught me that hurt doesn't equal harm, but it was in clinic that I lived that lesson and truly learned that my body was capable of progress, even through pain. A short session playing hockey with broomsticks and balls reinforced not only the neural connections between my hand and my brain, but my belief that I could still find fun and joy, even with pain. And while I often felt like the first pain management practice I was referred to was too quick to push spinal cord stimulators, and quite honestly a bit tone deaf in continuing to do so even after I kept refusing. But the PA and NP that I saw always took the time to answer questions. They sat at my level, made eye contact as we spoke face to face, and it was clear that they'd read my chart. It was me that they were looking at, not a folder of papers or an EHR screen. The single most meaningful encounter I had was probably even with one of those IMEs. Patients often see them as enemies, tools of an inhumane system whose only function is to invalidate our experience or expectations, prevent treatment. But that single meeting with a physician that I'll never even see again gave me such hope. He sat across from me, looked me in the eye, and stated simply, "Do you know how rare this is?" As affirmation, not accusation. What I heard is, "I believe you, and I understand your pain, even if others don't." He acknowledged how it affected me. He didn't judge when I got a bit sniffly. He just offered me a tissue and a lemon drop and, kindly offered to unwrap it for me, acknowledging my limited dexterity. He offered a suggestion on how to best get back into my jacket as I was leaving, and I was proudly able to tell him, "Hey, I've got this," and show off my excellent one-arm dressing skills. To be honest, these may have just been excellent ways to disarm me and test my functional limitations, but I didn't feel the need to prove my pain, display my disability, highlight the suffering. Because I felt heard. I felt understood. There was no treatment given, and yet that did more for my healing than any injection offered. I don't even remember this provider's name, and yet he left me this incredible legacy. Hope. What do you want your legacy to be? My career has been spent not in healthcare, but in philanthropy, where that's a question we explore a lot. What is the mark you want to leave on the world, personally or professionally? What's the impression you want to leave with your patients? Do you want to be the person who fixes my pain? Or the person who helps me understand I can live a meaningful life, even if it never goes away? Because it may never go away. I've mostly come to accept that. But I regret to inform you that it wasn't one magical conversation, one singular phrase bestowed upon my receptive ears by a wise clinician that descended from the heavens and helped me get to this place. It's a journey, a bumpy, sometimes really shitty journey. You're not going to be with me from start to finish. So instead, help me learn to be my own guide, write my own map and just walk alongside me for a while. Maybe point out some landmarks along the way so I can find my way back if I find myself here again. Because I probably will be here again. As the days are getting shorter and the weather getting colder right now, I'm experiencing heightened sensation, more pain in the arms and foot, new little pins and needles extending the fuzzy borders between affected and not affected body parts, new little doubts trickling in. My foot shows some of those objective clinical signs of CRPS, but my right arm doesn't, at least not often, not at the right time in front of the right clinician. And each time I get a new weird pain, the first thing I do is look at that body part, check to see if there's a sign that it's real. I've been so conditioned to disbelieve my experience. You might have been too. Do you believe me? Why? Is it because I've already been positioned here as an expert patient? Because the truth is, if you're treating patients, you have experts in front of you all day long. They may not have taken the time to learn your vocabulary, but I guarantee they know things about their conditions, about their pain that you don't. And that information might prove really valuable to your hopefully shared treatment plan and outcomes. It will definitely prove valuable to your shared understanding. I've been speaking for more than half an hour now, likely way longer than your average clinical encounter. Do you feel like you understand me? Even though you haven't had the opportunity to interrupt, ask me questions, correct my pronunciation, my misunderstandings. Have you found yourself imagining a treatment plan? What you'd do differently? Do better? What if I told you you're treating me right now? This might not feel like treatment, and I'm sorry you can't bill for it, but what if what I need more than anything is just to feel believed, to feel understood, to find meaning? It's in telling and understanding my story that this happens. Peter O'Sullivan recommends starting a clinical relationship with asking the patient to simply tell me your story. And that's incredibly powerful. Because in listening to me right now, you're providing that validation I so desperately need in order to move forward. I feel believed, even though I can't see you. Honestly, perhaps because I can't see your reactions, your facial expressions. How can you do more of that in your clinic? Because it's in listening to the story and recycling the words that I use, reflecting them back to me that I'll believe that you understand too. I did promise a deeper dive into the language. Did you notice the words that I used in telling that story? Or did you happen to notice how much longer it took when I told my story and not my charts? Or maybe that so much of my story focuses not on the physical sensations I experience, but the context in which I'm feeling them. I've spent the past year slowly infiltrating your world, learning your pain science, understanding the words you use. And since what I really want you to take away is the fact that it's my language that will make the biggest difference, in these final few minutes, I'd like to revisit a few of those. And unlike most of the patients you'll see, I've come to this clinical encounter with my very own PowerPoint, which makes it a little easier. So first, a reminder that early on, before I had an official diagnosis, the clinician quite rightly told me what she saw, or in this case, what she didn't. But what I heard is that my experience can't be trusted. That was just reinforced by a system that required me to show specific symptoms concurrently at a specific time in order to be diagnosed. And I felt like I needed that diagnosis, that name, in order to have my experience validated. But But validation doesn't only come through words. I know that the evidence doesn't necessarily justify manual therapy for pain reduction. But in my case, that touch was very much needed for me to believe that another human cared about me. It gave me hope and courage. I understand the need for evidence-based modalities, but I prefer evidence-informed. I'm a human, not a statistic. So tell me what the statistics say, but then reaffirm that I'm a unique individual, N of one. Tell me why we're trying something, but then also tell me that if it doesn't work, we'll figure out what does work best for me and my body. When I go into clinic, I'm not looking for an algorithm that can spit out the right combination of exercises. I'm looking for a human who can answer my questions and help me make sense of things, even if we don't solve it. And if what I'm presenting is beyond your scope of care, it's okay to tell me that, or to express your own reservations, the fact that you don't have an answer. Just make sure that you leave room for hope when you deliver that news. I still need to live my life, so help me discover my next steps, or at the very least, believe that I'm capable of discovering them on my own. Tell me if you're willing to stick with me. That lifeline can mean more than you ever realize. Yes, self-management is incredibly important, will be key to me living my life, but that can feel awfully lonely, really scary, without knowing that I'll still have support if I need it. And listen carefully, even when I do use your words. Speaking of touch, while we both might use the word allodynia to describe why wool sweaters suck, you may be thinking about overly sensitive skin, whereas I'm just wondering if I'll ever enjoy a hug from someone I love. The wind searing my skin doesn't exist in a vacuum, and what really hurts isn't the breeze, it's not being able to enjoy the kids' soccer games or enjoy a crisp, autumn day with my friends and family. And please be careful with the word perceived. Yes, there's a scientific understanding of the word perception, but that's not how I use it in my everyday life. It connotes subjectivity, which with an unbalanced power dynamic in a clinical encounter can very much sound like, you might feel this, but it isn't real. You heard plenty of yellow flagged words coming out of my mouth here, but don't waste your time trying to convince me that the system I've experienced isn't broken just because there are thousands of compassionate clinicians working within it. Just help me rediscover my locus of control. Acknowledge that my pain is my authentic experience without the need for that subjective modifier. Say what you want amongst colleagues, but remember that the words you chart may eventually be seen. And the words that you use every day burrow deeper into your lexicon and can pop out at inopportune times. I'm not your 3:00 elbow appointment. I'm Kat. And you won't even know my preferred name unless you ask. Even the word pain, 4 little letters. Yes, it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Very smart people have been tweaking that definition for years, classifying types, arguing over whether nosoplastic is really a thing. But my understanding of pain, what it really means to me, is fear that I'm losing control of my body or my health. That intense cognitive dissonance that comes from having to reimagine who I am and what I'm capable of. It's the damage it causes to relationships, to my place in society that hurts, not tissues. It's learning to accept not just discomfort, but potential uncertainty that matters. A willingness to walk into a murky future and still believe that I have the power to get better. And yes, I needed pain explained. I had to read the book myself, but in trying to explain it to my physical therapist, it solidified my own understanding. If you feel like you're struggling explaining pain to me, why not allow me to explain it to you instead? And we can arrive at a shared understanding together. Because grasping those concepts was absolutely life-changing. But so is sharing my understanding with you. I'm unfortunately a lot more complicated than pain, and pain is more complicated than a joint, a simple elbow. Don't focus on my pain, focus on my ability to cope. Don't tell me why I'm injured, tell me why I'm hurting, and help me discover what I can do to affect that experience. When you take the time to understand, my path to recovery becomes clearer, and that's not just me saying that, it's science. Language Language is just a tool to describe, to connect, to reflect. There aren't, unfortunately, any magic words that will solve my problem with pain. The right language doesn't replace context, it's part of it. Communication, good communication, takes time and a concerted effort, not just to teach, but to listen, especially to listen. So thank you for listening to me today, for being a part of the clinical team that has helped me to learn and grow, that is helping me recover, whatever that ends up meaning for me. I'd love to continue the conversation actually here or on social media via email. In fact, that handy little QR code that just appeared will help you do just that. Thank you, especially for continuing to listen to the many N of ones that you will see in the coming days and months, and for seeking to understand those experts just as you have me. I want you to understand what a difference that really makes. So thank you for listening to me today, for being a part of the clinical team that has helped me to learn and grow, that is helping me recover, whatever that ends up meaning for me. I'd love to continue the conversation actually here or on social media via email. In fact, that handy little QR code that just appeared will help you do just that. Thank you, especially for continuing to listen to the many N of ones that you will see in the coming days and months, and for seeking to understand those experts just as you have me. I want you to understand what a difference that really makes.
Hi. Thank you
Hi.
for that, Kat. Gosh, I was trying to tweet fast and I think I only actually got like 2 of them out because you were saying so many things where I was just like, yes, that and that too. So I think I'm gonna craft a better tweet that's something like if you listen to one talk, I would recommend practitioners who haven't listened to patients outside of the clinic yet, listen to this. Even if you have, listen to this anyway, but I feel like your message was so so much. And really, even though I try to be thoughtful, I think will make me even more thoughtful because I do think about that patients, I assume patients will read my notes. And I know that those words matter, even if you don't ever read them. So thank you. So I'm a little, I don't know why I'm teary. But anyway, so thank you for that. We're going to get into the questions. So here we go. Is it possible for you now to look back and identify at what stage you should have been given a different message or approach? And if so, what would that message be?
Yes, absolutely. And that answer is before I ever experienced pain. I think that when we look at community health, that the messages that we as a society share about what it means to hurt, to show, to feel, to express pain, that if we had that understanding before we started living that experience, it would completely transform what it's like to live in a body like this. If, maybe in a future world, it would transform the healthcare system itself. These understanding what pain is, not just from a lived experience, but the biology, the physiology behind it is important. Incredibly important for me, and that's when I first started to accept, maybe for the first time, that this was real, that it wasn't in my head, that it wasn't a weakness, that there were real reasons for what's happening in my body. And to have gone into that, having that understanding before I experienced it would have made, those first months so much easier. And in fact, it's funny, I barely talk about it in the presentation, but I've been living with trigeminal neuralgia long before the CRPS occurred. And that I can't say I ended my career, but I was at an executive level. I shifted my career. I believed when I was reading that especially in other patient spaces, that this is a chronic progressive disease that will only continue to get worse. And I was preparing for that instead of preparing for recovery. It wasn't until GMI appeared in my life that I started understanding pain science in a different way, and that I started reclaiming control, and I started trusting myself in my body again. So the earlier, the better, essentially.
I love that idea of working out pain, or understanding pain better, perhaps before even pain starts. And Rajam has had other great speakers at the San Diego Pain Summit last year. Melanie Knoll was talking about how experiences with pain in childhood, and actually how adults react to you really has an impact in the future too. So I agree, that might be a way to make a much bigger difference in the world, is to I don't know, let people understand pain before they have it. Or as
and
they have
Melanie
it.
Knoll, I think, does a good job of discussing this as well. It's not just, it's not just my conception of pain. It's not just what my providers believe, but it's society as a whole in those messages that affect everything in my understanding.
Mm-hmm. Yeah, it's bigger than I think we used to think. Okay, so the next question. Wow, thank you so much for sharing this. This presentation is so heartfelt, and I'm so glad you found Therapeutic Alliance. How did they approach you with GMI, and what were your initial thoughts? From Gina.
It's crazy. It's absolutely insane. And again, and for me, it was helped because it was someone I loved and trusted who first brought it up, my sister, who's an OT. So it wasn't someone where I didn't have a relationship with that first said, well, okay, your arm may hurt, but let's just pretend that isn't your arm, that this other arm is really that arm, and it's going to make everything better. No, that's insane. But because I went into it with a certain level of trust, and at that point, I devour information as much as I can, and because I think so much of what I was reading made sense, was like I said, was in a language that I understood coming out of Noy Group. It was a little easier to accept. Now that said, I access my emotions fairly easily. The first time I'm sitting in front of a mirror in clinic, I broke into tears just because it was so weird. And later, I would get teary again as I started having the quote unquote good arm affected, and wondering, what that means. It's to sit there and, it's just the reconceptualization of self isn't just on a society level. It's on a physical level, especially with something like CRPS, where my arm doesn't feel like an arm, doesn't feel like part of me a lot of the time. And so having little experiences where I reconnected with that, even in kind of a crazy kind of modality like that, was really powerful. And in GMI, of course, it is graded. So it's not just the mirror therapy, but I've been doing work on left and right differentiation, on Imagine movement before I started with that. It's fascinating. And if anybody's interested in that, I absolutely recommend that you do further research.
Awesome. Thank you for that. Let me see here. No question, just thank you, which doesn't seem to be enough. The patient view is so important, and I'm thrilled the San Diego Pain Summit keeps bringing this to us. From Julie. Thank you, Julie. And then we do have a question. Great message, thank you. My question is, what is your relationship with your physical therapist now? Have you brought him along with your understanding of pain science?
Oh, I miss him. I do. So I've been discharged from that practice at this point. That has more to do with a third-party payer system than it does my actual progress right now. And I think honestly, one of the best parts of that relationship is that I had someone along with me on this journey, that was witnessing as my understanding changed. And in one of our last clinical encounters, we were even laughing, and he said that, conversations with me tended to be a lot different than conversations with many of his other patients, as I was bringing forth information, questions, my own understanding. He is a young clinician, was just about 18 months, graduated with his DPT when we started. As I referenced, I'm in a very rural environment where there isn't a lot of access. I believe I was maybe the second person with CRPS he had ever seen. And so we were doing a lot of this learning together. But I mean, that too, not just him, but the PTA that I worked with as well, they would be doing research in between sessions and coming up with ideas. And that, again, just that show of care and understanding that I existed was so powerful. And he knows that I was speaking at this conference. I haven't shared my presentation with him. But what I think is important too is that you don't have to be perfect. You don't have to be David Butler, to offer up GMI in a clinical setting. It's enough just to be there and to be human and authentic and say, hey, you know what? I don't know if this is going to work for you, or maybe this is not something that I myself have done before, but I'm here with you and we'll try it together and see what happens.
Awesome. Thank you for that. That's my favorite. Thank goodness we don't have to be David Butler in order to apply any of these principles, because I am not that snazzy of a dresser. I am not that good of a storyteller, and I'm not that good of a dancer. So yeah, thank goodness for that. Okay, so it's about time to head over to the discussion. Kat's presentation will be made free for anyone to watch on SanDiegoPainSummit.com under Patient Resources tab. So that's great. I don't know if this would be fair, but I feel like I'm going to direct a lot of clinicians to the Patient Resource tab on the San Diego Pain Summit, because again, I think this should be essential listening for pretty much anyone who's going to be working with people, especially if those people are coming to them because they hurt.
Yeah.
So any final thoughts before we scoot on over to our backstage Zoom meeting?
Just again, thank you for listening. I'm looking forward to the backstage path with individuals. I'll also be at the fire pit again later to continue the conversation with others.
Okay, awesome. So everyone, we will see you a little bit later. And everyone with backstage passes, I'll go open up the Zoom meeting.